right now, we actually get to hear from Dr. Jeff David, who he's a local here. He's trained here and everything, and Dr. Jonas Peterson. We're going to talk to us kind of about mental health. Yeah. Thank you so much.
Okay. Hello, everyone. It's a pleasure to be here. So I am Jonas Peterson, and I'm presenting with Jeff David today. We wanted to share a quick message about some of our reflections, our thoughts about caring for those with mental illness. And so anybody here who has patients that are human beings, this will be a germane topic. So no real significant disclosures, at least for our topic today here. Jeff David and I work at Weber Human Services. We graduated from the residency program over here at McKay, Porter Family Residency. We are family practice physicians, but we are passionate about mental health and caring for those that are underserved and struggling in various ways. And since my esteemed colleague, Jeff David, wants to share a lot of information with you guys, I'm going to try to be real brief so that he can get through as much as he wants. So real quick, though, Weber Human Services came about as a collaboration between Weber and Morgan counties. It's been around for more than 50 years now. It has the goal of providing services to individuals with mental illness, substance abuse, and also they have a whole bunch of senior services available. And so we accept all forms of Medicaid, some private insurers. We have a sliding scale fee for people who are uninsured, and we have some grants as well to pay for various programs. And some of them in particular that I think probably a lot of people here would find interesting is that we do have a grant for those with substance use. If they don't have insurance, they don't have money, we have ways to help pay for their services. And so it's helpful, I think, for you guys to be aware of that in case you have anyone who has substance use disorder and needs treatment. Real quick, so everybody's aware, we are located between, I have a little down at the bottom left there, is where we're at. We're between 26th and 27th Street, kind of close to the Ogden Municipal Building. We're like kitty corner from there, just southwest of that Ogden Municipal Building. And we have a bunch of services. So again, I mean, greater than 95% of people that we're seeing have Medicaid, Medicare. We don't see a whole lot of people with private insurance, but we do accept a few of those as well. But services that are available, in particular, if you have Medicaid, we have individual therapy with therapists, group therapy. We have a bunch of great case managers who get to know the clients. And some of them have been working with the clients for years. They get to know their name, they know where they live, and we have vehicles. So in the background picture there, some of our vehicles that we shuttle people around. The case managers, as they identify needs with these clients, they take them grocery shopping, they take them to their doctor's appointments. They may have shown up to some of your appointments with the clients, and they just help them navigate life. We have a residential treatment program for both men and women. So Stepping Stones for men, Tranquility Home for women, where individuals can stay for 90 days. Generally 90 days, I think there's some leeway there, possibly even staying longer. And as they're there, they're receiving education, therapy. They are coaxing them into establishing healthy habits and routines, getting them employment, and starting the application for housing and different things like that, so that as they transition out of these substance use facilities, hopefully they have somewhere to go, as opposed to, the street or their families or other places where substance use is a problem still. We have a whole bunch of stuff that we do as far as aging services, Meals on Wheels, the senior citizen centers, there's advocacy for the elderly, and just a whole bunch of stuff. So senior volunteers, things to help those who are aging. One of the things that sets Weber Human Services apart from other mental health facilities is that there is a a real emphasis on doing evidence-based practice. And so I attribute that to our directors, a couple of whom are here today. They really make an effort to identify and implement evidence-based practice. And to all of us here, it wasn't always that way in medicine. We used to shoot from the hip and treat according to our own preferences, but lately in medicine, the big topic is evidence-based practice, right? And algorithms, and how do we maximize our efficacy in treating patients? That hasn't quite caught on in the mental health field, but there are evidence-based psychotherapeutic treatments. They're just not being implemented very well or very often by people who are even trained to do those things. They just are not. There's not that same evidence, but that's something that is occurring at Weber Human Services, and that does set us apart. And because of that, our outcomes at Weber Human Services are better than at other mental health facilities throughout the state. And so Dr. David and I, as we've worked at Weber Human Services, we're very passionate in figuring out ways to take care of these individuals. Our heart feels for them. We really want to do something to make a difference in their life, but we've often found it to be a little bit of a balancing act. If you just throw services at them, you don't necessarily do them a service. And so we have really been working to figure out how do you throw services at them, but also help them build strength and resiliency and the skills that they need to be successful in life. And that's been a challenge. And we've really run into a lot of things that have made us stop and reflect on how challenging it really is to deal with those with mental illness. And so I'll turn the time over to Jeff David, who will elaborate.
All right. It takes a lot of help to keep me going, as you can tell. So in 2018, I left clinic late one night during a rainstorm, and one of my patients with schizophrenia was standing outside. And I asked him if he wanted a ride, and he accepted. And he climbed into my minivan with my seats decorated with Chick-fil-A sauce and Cheerios for my children. And he looked around, he said, "So you're like a real doctor?" And some of you may be wondering the same thing. So by way of quick introduction, I am a family medicine physician. I trained at McKay Hospital here locally. I'm a recovering drug dealer. I was a pharmacist before going to medical school, and then decided I didn't have enough student loans, but I do now. And during residency, I started moonlighting at Weber Human Services. I had an interest in substance use disorder specifically, and they were kind enough to let me work there part-time, and then afterwards offered me a position as their medical director. And I'm not a psychiatrist. I'm not a mental health expert, but I have had the privilege of spending a lot of time with people at Weber Human Services who have suffered exquisitely because of mental illness and have some familiarity with it for that reason. At a conference that I went to for Weber, I met a philanthropist and pastor named Mac McCarter. And he, when Jonas and I went to visit him this last summer, he shared a scripture with us, actually, from the book of Ezekiel that says, "Then I came to them of the captivity that dwelt by the river, and I sat where they sat and remained there astonished among them. At the end of 7 days, the word of the Lord came unto me." And he told Jonas and I that if you're really going to help people, you need to spend time understanding their circumstances. You need to be with them. And so that's the one qualification that maybe I bring to this, is that I have been able to see the suffering of these people, and I can say that it is astonishing. And we're here to share some of the things that we're doing at Weber Human Services to address that. So speaking of people who are experts, this is Dr. Thomas Insel, and he was the director of the National Institute of Mental Health for many years, responsible for budgets upward of $20 billion. He advised presidents, worked with Google. This guy knows what he's talking about when it comes to mental health. And so I'm going to lean heavily on a lot of his research and his book that was published last year. And therein, he describes 3 big sequela of untreated mental illness, which I've labeled as death, disability, and dollars. And essentially what follows are depressing statistics about how mental illness is bad, but just, you can get more details from the slide specifically if you want, but I'll just quote a couple things. Suicide on average is occurring about every 11 minutes in the United States. Most of those suicides are due to mental illness. When these people die, it usually happens about 23 years before patients without mental illness. And they die from things that kill normal people, heart disease, obesity complications, etc. With regards to disability, mental health problems are the #1 driver of disability in the United States. And unfortunately, that disability usually begins at an early age in their 20s. And so you're looking at down the barrel of a lifetime of disability that affects these people. And when you look at the numbers of people that are struggling with this, there's about 1 in 5 in the US that has a mental illness, quote unquote. But we call that a serious mental illness when it starts to affect their ability to function. And things that qualify for serious or qualify as serious mental illness include things like schizophrenia, bipolar disorder, those things that are really debilitating, and that affects about 1 in 20 people in the United States. Last D, dollars. So caring for patients with mental illness is one of the most expensive things that we deal with in the United States of America. And the lifetime burden of paying for the care of someone with mental illness is about $1.8 million when that person is diagnosed in their 20s. And when you look at Medicare's budget, this ends up being more than 10% of their funds are used to pay for this. And with Medicaid specifically, their patients that have mental illness on average cost about 4 times as much to take care of. So there's huge problems that occur when mental illness is untreated. And Dr. Insel, in his book, he offers some suggestions as to why that is, and kind of the root of the problem, if you will. And our director of clinical quality, Darren Carver, who's with us today, he had the insight to realize that there's 3 big things that drive mental illness that we need to focus on, and that is engagement, intervention, and recovery. And I'm going to spend the rest of my remarks today talking about those 3 words. So if you don't remember anything else, remember those 3 words: engagement, intervention, and recovery. And so Dr. Insel, with regards to engagement, says that mental health care is delivered ineffectively and mostly accessed during a crisis here in the United States. With regards to intervention, he states that current treatments work, but like Jonas said a moment ago, not all of them do, though. And lastly, when it comes to recovery, it's more than just eliminating symptoms, bringing down the psychosis. That's not living. What we need is a life with people, place, and purpose. And that is the best definition of recovery that we've been able to find. And we've been thinking about this for a long time at Weber Human Services. And so much so that over the last 3 years, as we've gone back and forth contemplating how we can align our agency around these ideas, we finally decided that we need to alter our mission statement to get everybody on board. And this is going to sound like a corporate treat here for a minute, so just bear with me as I get through this. But we knew that some of the principles that we wanted to incorporate into everything that we did were the ideas that mental health, again, is more than just blunting psychosis. It's more than bringing down anxiety levels. You need relationships. You need a life with people, place, and purpose. That's the same thing that we need as the staff at Weber Human Services, and we realize that it's ludicrous for us to expect or think that our patients would need anything less for mental health than we need ourselves. We need relationships. But you can't give those. That's not something that can be passively given or received, like Jonas said. It requires work to develop the skills, the attributes, the abilities that are necessary to serve other people and thereby sustain those relationships. And so when we packaged that all together, what we came up with was this mission, motto, and methods. And there's small print there, so forgive me. Essentially, what we were trying to figure out is how can we incorporate these ideas of engagement, intervention, and recovery into everything we do as an agency. With our methods, when we're making decisions, we realize that we want to maximize engagement. We want to make sure that our interventions, the things that we're doing, have data to show that it's worth the patient's time to do it. And then we want to keep that idea of recovery as people, place, and purpose, as relationships in our mind with all the decisions that we're making. But it's kind of hard to motivate staff saying, just engagement, intervention, recovery. And so when we're teaching and explaining to our staff what we mean by this and what our purpose is, we explain to them that our goal, our objective, is to create opportunities and hope that enable all patients and staff to do the work necessary to become their best self and find joy in helping others do the same. We want to help them engage to do the work. We want to help them become their best self to participate in an intervention that can change who they are and what they're capable of doing. And then lastly, recovery. We want to help them get into a life where they're in a position to experience the joy of serving and being with other people, their family, their community, their coworkers, et cetera. When we're talking to patients, we again push that idea of engagement, intervention, and recovery, telling them that it's going to be necessary to do the work. You're going to have to engage. You're going to have to change and become a better version of yourselves. And we have evidence-based interventions that can help you succeed in doing that. And then lastly, we want to remind them that we're doing this so you can be in a position so you can help others become their best as well, so you can have those relationships that make life meaningful. So that sounds like a bunch of jargon, and I'm going to talk about what we're doing specifically to help implement that. So essentially, we're trying to use our mission model and methods to incorporate these ideas of engagement, intervention, and recovery into everything that we do in our agency. I'm going to start with recovery and work my way backwards, because that's the goal. So when we say recovery, again, at We Were Human Services, what we mean is mental health, is people, place, and purpose, is relationships. Relationships matter most. And this isn't some idea that we just came up with off the top of our heads. This is Dr. Waldinger. He's a psychiatrist at Harvard. He's responsible for managing the Harvard study of adult development, wherein they've monitored 700 plus adult men for the last 80 years, looking at what makes a good life. And they've expanded the study and incorporated their family members, and it's ongoing today. And what they've found consistently over and over and over again is that relationships matter most. Good relationships are the highest predictor of your quality of life. It's not your health, it's not the amount of money that you make, and this is something that we all innately know deep down. This is something that's backed up by thousands of years of literature. It's something that we all know from our own experience. And this holds across generations, it holds across ethnicities, it holds across geography. Relationships matter most. And if you talk about mental health without relationships, you're wasting your time. So how would this affect a patient? So when I meet with a patient at the beginning and I'm trying to establish, what do you want in life during our first visit? It's helpful if we can help them see this idea, this endpoint. So a patient I met with a few months ago, when I asked him this question, he said, before my mental illness got out of control, I used to have a job putting in awnings over gas stations. And it may sound modest to some, but to me it was really meaningful. And I was proud of it every time I drove by. And most importantly, I had a place where my family, my kids could come spend time with me on Thanksgiving and Christmas until my mental illness got out of control. And I'd really like to get back to that. Someone with that kind of why can endure any kind of how. And so then if we keep that idea in mind, then we can help them do the work that's going to necessarily follow, because this guy might need to get into he might need to see our psychiatry folks and be on antipsychotics. He might have diabetes that needs treated. He's going to have to come see Jonas and I. He might need prescriptions that our pharmacy is going to have to package into daily meds for him, depending on how bad his psychosis is. Our nurses are going to help facilitate that and check on him every day. Our case managers might need to go pick him up from his house. They might need to help him with employment forms. He's going to participate in individual and group therapy. He might need to go into one of our residential facilities. He might need help with, employment or whatever. There's a whole bunch of things that he's going to have to do, but if he has that idea of recovery, that people, place, and purpose idea in mind, then he's more likely to be able to get through it and be successful in entering into recovery, because he knows what it means. So again, at We Were Human Services, we want to visualize recovery as a life with people, place, and purpose. When we're trying to think about partnerships with outside organizations, because We Were Human Services isn't a stop point. We want to get people out and back into life. And so we try to make partnerships with agencies that can help us introduce patients into that world of people, place, and purpose. We try to reiterate that when we're talking with our patients, helping them remember that you want to do this so you can get yourself into a position where you can help your family, your neighbors, your coworkers, et cetera. And we tell our staff that our job is to help people find joy in helping others. So that's recovery. You got to have the ability to serve others to get into recovery. You have to have some skills and abilities to serve others. So how do you develop those skills and abilities? And that's where we talk about the evidence-based interventions that Jonas mentioned previously. So Dr. Insel, again, told us that current treatments work, but not all of them. It's interesting that unlike other fields, therapy still has a lot more leeway in what qualifies as therapy, and there's not one single body that governs and oversees the quality of therapy, and that makes it really challenging. So at We Were Human Services, for the past 13 plus years, we've been trying to employ and institute as many evidence-based treatments as we can. And there's a lot of things that go into mental illness. There's the genetic component, there's the environmental component, there's the behavioral component. And we can give people housing, we can give people medication and try to help with the environment and help with the genetic aspect of things. But if we don't change the behavior that's driving the mental illness, then it doesn't really matter what else we do. And so our most effective tool for changing behavior is therapy. And Dr. Insel laments repeatedly in his book about how the problem in the United States isn't finding a therapist, it's finding a therapist who knows how to provide treatments that work. And those treatments that work, they're hard to institute because they're expensive. It takes a long time to train your staff to fidelity to be able to provide those interventions. And even if you have staff that's trained, it's hard to get patients to engage in it because it's a lot of work. All of you have had the experience, or most of you probably, of sending someone to physical therapy and you kind of a little bit feel like a snake oil salesman because you don't really believe it's going to make a difference. Not because it couldn't, but because usually they're not able to engage with enough intensity and frequency to make a difference because of insurance problems or lack of motivation or whatever. So getting someone to participate in the rigorous evidence-based treatments that have data to support them is challenging, but we've tried to do that, and we've been doing it for the last 13 plus years. We've been trying to do this. When we started early on, we used this study. It's getting really old now. It's like 2002, I think. But what they showed in this study was that when you look at naturalistic therapy, a therapist who just kind of takes the experience that he's had and compiles it together to make his version of doing things, patients are going to get better about 25% of the time. If you use an evidence-based treatment, they found that people got better about 63% of the time. That's a big difference. And so what we decided to do was, and this is more of that study, and you can see the range of outcomes that they had. On average, those people were getting better 63% of the time. In the state of Utah, that average is closer to 43%, so it's better than what was in the paper. And we decided that we were going to shoot for that middle third. A lot of our patients have serious mental illness, schizophrenia, bipolar, and whatnot, so this was an aggressive goal for us. But we wanted to get outcomes in that range. And so if you look at the community behavioral health centers in the state, you can see a range of outcomes around that 43%. Weber Human Services is a little bit ahead of them when you look at all of our treatments. But when you look at our evidence-based treatments specifically, we get outcomes that are closer to that 63% range. People get better more often if you're doing something that has evidence behind it. Big surprise, right? But that's a foreign concept in therapy. And this is true in our pediatric population as well, and even better there, actually. So when we look at their evidence-based treatments, their outcomes are exceeding our goals in some areas and averaging 68%. So at Weber Human Services, we've made a lot of effort to drive this idea of making sure that we have evidence-based treatments and that we prioritize those so that when we tell patients, we want to help you become your best self, and the work that we're asking you to do has data to support that it's going to work and be worth your time. And so that's what we're shooting for. I think I got to speed up here. So again, back to our overall objective, we want to help people have the relationships that make life meaningful. They have to be able to serve somebody to do that. They have to have skills and ability to serve the people around them. And our evidence-based treatments can help them acquire some of those skills and abilities. But how do you get people to participate and engage in those evidence-based treatments? That's the big question. The most common number of visits for therapy is 3. The average number is 3, and the most common number is 1. It's hard to get people to be willing to do the work. And there's 3 big barriers that I wanted to mention today that help or contribute to that difficulty with engagement. One is refusal of care. Unlike people with cancer or other serious medical conditions, people that have mental illness oftentimes refuse treatment. Patients with schizophrenia are so suspicious that they're not willing to engage. Patients with depression are so sad they're not willing to come. And so it's really hard to get these people to have the motivation to do the work, to engage in treatment. So that's problem number 1. Problem number 2 is fragmented care. Someone may need to go to all different corners of town to see their primary care provider, their psychiatrist, their therapist, their pharmacy, their case manager, and this becomes more challenging when you're poor. If you don't have ready access to transportation or communication, you're more likely to no-show your appointment with the specialist, and then you're going to get discharged from the clinic, and then you're going to have to go even further to find another specialist, and you can see it's just kind of a vicious cycle that develops. Additionally, it's hard to coordinate care amongst these different organizations because it's 2023 and we're still communicating with faxes when we want to share records. It's crazy, but that's the way it is. So that fragmented care is really challenging. Lastly, the cost of care. There's barriers to paying for care, whether it's physical health care or the mental health care these people need. When it comes to hepatitis C, for example, Jonas and I diagnose people with hepatitis C like every day, and we should be able to treat it, but insurance companies won't pay to have it treated in a primary care setting. And so you have all these people that could be treated easily. We could do it right there, but we can't get reimbursement for it. And so we have to refer them out. And sometimes they show up to the GI office, and sometimes they don't. And so then they infect other people, and it just goes on unnecessarily. Lastly, the mental health side of things. Interestingly, many mental health providers, therapists, and psychiatrists in the United States don't care for people who, or don't provide care for patients who are the sickest. So if you have schizophrenia, bipolar disorder, many of the mental health care workforce members won't see you because they can't get adequate reimbursement from the insurance companies. And so then you end up with a fee-for-service scenario that penalizes people who are the sickest, because these people are usually poor and they need these services, but they can't afford them. And when this doesn't happen, it goes really bad. So, how much time we got? A minute? Okay, a minute. So, arm on the left, a gal that had an abscess in her arm, and she went to an ER to get help, and she felt kind of ashamed by the way that she was treated. And I don't know if she was treated badly, but she felt that they thought she was less than a human being. So when this abscess got worse, she didn't go back until it was to this point, and she nearly lost her arm because of it. The picture on the right, we have these same problems with engaging people at We Were Human Services. When I saw a patient last year, the year before, and I watched him just kind of decline slowly over a couple months, and I was sending messages to case management, hey, we need to get him into a treatment facility, he's getting worse, we need to do this, we need to make these changes, and they're like, oh, well, he hasn't had the required number of visits with his therapist yet, he hasn't done this, he hasn't checked this box, and eventually he got so discouraged he tried to commit suicide via law enforcement and was shot multiple times. Fortunately, he lived, but when you fail to engage people, things go really, really bad, and these are just a couple examples of that. So, what are we doing to address engagement at We Were Human Services? We try to make sure that our case managers and our therapists are reaching out to people on a regular basis, even those who refuse care. You have to try really hard also to get kicked out of We Were Human Services. We might time you out for a day, but we'll bring you back the next day usually. We try to make sure we have flexible scheduling that they can walk in if they need to. We try to question ourselves when we put barriers into place, like is this policy going to hurt someone? Is this going to inhibit engagement? We try to work with the legislature on reimbursement strategies to provide care in community behavioral health centers like ours. We're trying to work on addressing coverage gaps with insurance companies, utilizing grants, like Jonas said, for people who don't have insurance. And then lastly, with regards to the fragmented care, the reason that Jonas and I are here today is because since 2019, we've been running a primary care clinic out of our community behavioral health center where Jonas and I work, and we have been able to help coordinate a lot of these things that that Jonas and I have talked about today between psychiatry and therapy and case management and so forth. And we've been able to do it under a single EMR. It's an EMR that we cobbled together and made in our basement with our own IT department, but it's still a single EMR. And we're hoping to address that fragmented care aspect. And so, in closing, we're trying to maximize engagement so that patients, when we tell patients, you've got to do the work, that we can set them up to succeed through helping them to engage in treatment. So again, big ideas, the big things that are driving, or the three big problems that we're trying to address at We Were Human Services. We're trying to help patients engage in the treatments that are out there. And I'd encourage each of you in your own practices, please be patient with these people. They're hard to work with sometimes, so am I, so is everybody else. But please do what you can to help them engage in treatment. Please encourage and direct them towards evidence-based treatments that work, and encourage them to do the work necessary to proceed through those interventions. And then lastly, help them to keep that idea of recovery as a life of people, place, and purpose in mind. Help them in your life outside of clinic. When you have a chance to sit down and talk to that patient in a setting that's not just in the clinic, or to interact with them or to support them in the real world, take the opportunity to do it. So anyways, that's kind of the direction we're trying to go, and I probably don't have time for